and aren't used to walking 8 to 10 miles throughout the day, that's pushing themselves beyond the limit of what their typical conditioning is. A lot of times navigating rugged terrain, northeastern South Dakota is rugged. There's a lot of topography changes, ditches, valleys, things like that. And oftentimes people, when they're hunting, they're distracted. They're paying attention to, the game that they're chasing, whether it be deer on the horizon they're looking for, or waiting for a next rooster to jump up or ducks to fly in. A lot of times they are not paying attention to their surroundings. And so I think a lot of this leads to people being clumsy, and that clumsiness can lead to different musculoskeletal injuries. I also think, when you think of musculoskeletal injuries, you can see these catastrophic injuries. I think a lot of times the thing that comes to my mind is people hunting deer, particularly from tree stands, in a situation where you're scaling up a tree, you're trying to hang a metal stand in the tree, and you're getting pretty high off the ground, to where if you fall in that situation, you can have falls over, 10 feet pretty easily. Let's see. So going kind of hammering out, some of those things that we just talked about, thinking of terrain in different, hiking areas. A lot of times you think of, topography. So people are going up and down hills. There's rocks, there's loose gravel, more likely to trip. We see a lot of ankle, a lot of leg injuries due to that. Thinking badger holes, different varmint holes. It's pretty easy to be out in the field walking, and next thing you know, your foot's 3 feet down in a big hole. That's an easy way to break an ankle or sprain an ankle in the middle of nowhere. A lot of times, with people pheasant hunting and things like that, maybe walking on frozen sloughs, those types of settings, early ice conditions, maybe more likely to go through the ice and twist an ankle or hurt themselves in that regard. So I think, when I start thinking about EMS and responses to those types of injuries, realistically, a lot of your initial evaluation is going to be involved on, can the person mobilize? Are they able to bear weight? Are they able to move it? And, do they need immediately seen? And if so, we probably need to get this splinted until they can be further evaluated. There are all sorts of different types of splints used within EMS, and I'm sure, everyone has different familiarities. These are, some different types. I think commonly nowadays, even more so, seeing a lot of SAM splints, or a lot of the, inflatable splints where, you can fill them up around someone's leg and form a tight fitting splint that way. If you have someone who's fallen and they have multiple injuries, backboards, not only is that a way to get someone out, but that's a way to kind of splint their entire body, to get them on something rigid so that they're not moving and making injuries worse. Traction splints. So back when I was in EMS, we always had a traction splint in the ambulance. I'm not sure kind of how your guys' facilities are nowadays. Traction splints are kind of coming in and out of favor a little bit. I know a lot of times when we see different femur fractures and those types of things in our facility, orthopedics nowadays is recommending less and less use of traction splints due to the risk of nerve injuries. Now, I think definitely, if there's vascular compromise or things like that, there's times when a traction splint can be nice. But we think of those, for more your big long bone fractures. Getting to kind of, some of the catastrophic falls, I think what I think of most is a tree stand. Someone is 12 to 20 feet up in the air, either on a ladder or a hanging stand that's maybe hanging on by just, a strap or two. Not only that, but they're holding a weapon while they're doing it. They're paying attention to other things. They're maybe leaning out far. It's cold winter, so they got 27 layers of clothes on, big bulky boots. Their feet are numb. It's just something that can happen. I personally fell out of a tree stand deer hunting when I was in my teens. Fortunately, didn't have any major injuries, but it could have been very severe. I think the biggest thing, nowadays is pushing people into safety harnesses as a way to try to keep you as safe as possible in the tree. But even if that happens, if you fall out of a tree, next thing you know, you're kind of hung suspended up and you're swinging through the air. That in itself can cause some injuries. I think in general, when I think of, people falling from tree stands, I think of if you are called to an incident where someone fell out of their tree stand, they can't get around, they probably have multiple injuries. Like, it's very rare that you fall out of a tree stand and have one isolated injury. Most of the time you're thinking mechanism of action, you're worried about possible neck injuries, you're thinking about collaring, immobilizing the spine until you can get them to your local facility. Thinking about extremity injuries, worrying about internal, abdominal bleeding, things like that. And so, I think most of the time in that situation, I think about trying to mobilize that neck. I know most of you have, gone through this numerous times, but I always think sometimes the things you don't do every day are the things that are maybe worth revisiting. And, fitting a C-collar or something, it's easy to slap a C-collar on, but you want it to be on right. Typically the finger breadth from the shoulder to the chin is a good way to measure, comparing that to your collar size, getting that fit before you try and apply it to the patient, while also having someone manually holding that patient's head to reduce the risk of jarring or moving that neck during the fitting process. I also think a lot when I think of hunting injuries regarding, environmental exposures. People are outside in the fall and the winter when our South Dakota weather is just nasty. I think a lot of times this is where you're more likely to see people with frostbite, maybe hypothermia, different drowning type injuries. And that's definitely something that you might notice, more in kind of the hunting community than just the general population. One second. Let's see if I can change this. So going to, different types of injuries, I think a lot of frostbite is something that you may see someone, and this can honestly even be outside of the hunting community. You find a person down or intoxicated individual outside in the winter. It's not going to just be your hunting community, but there's different stages of frostbite, different severities. In general, frostbite starts from, more of like a reddish discoloration. Those fingertips might just be red and irritated. As it gets more progressive, you might start to see some blistering, some more pallor of the skin. And then it ultimately ends up where deep frostbite is involving the whole epidermis, dermis, subcutaneous tissue. You're getting widespread necrosis of that tissue, and then you start to see that blackish discoloration. Frostbite essentially is the severe cold causing these freezing injuries to the tissue, where you get this crystal formation within the tissues that causes long-standing damage. Going back a little bit to the staging, we think of kind of a first, second, third, fourth degree. And for the most part, that first degree is going to be that superficial, as we talked about. The treatment of first degree frostbite is going to primarily be just localized warming. Removing any wet gloves or wet socks, trying to warm with either ambient temperature, such as body temperature. Sometimes, if people have hand frostbite, getting their hands into their axilla so that they can use their body heat to warm them up. You can use warm water, but you definitely don't want to use hot water. And so there's kind of this fine line on water use for that. The other thing to kind of think about is avoiding, walking on frostbitten feet, particularly as you get second, third, fourth degree frostbite. You can actually cause more damage the more that you apply pressure to that tissue, the more that you exert and kind of damage that frozen tissue already. And so, if you're getting called out into the field and someone that has frostbite of their feet, really not wanting them to walk to the ambulance or walk to the facility, you really kind of want to get them off of those extremities until we can get them warmed up and that tissue perfusing again. And kind of saying that, often a good thing to do is to actually pad or splint the affected area. And so that kind of prevents it from getting jostled or damaged more. Hypothermia kind of goes hand in hand with frostbite. I feel like you usually see those together. Hypothermia is something that I think most people have experienced the very early stages of at some point in their life where they've, maybe gotten too cold for a period of time. But it's pretty rare that we see it getting to the severe stages. Initially people might be a little bit confused, shivering, have some difficulty speaking, sleepiness, stiff muscles, and things like that. But as it progresses, it can get pretty severe. Again, similar to frostbite, hypothermia kind of comes in stages. And so cold stress is not really true hypothermia, but that's where your temperature is dropping down in that 95 to the 98.6 range. You're getting cold, your core temperature is dropping, but it's not causing really any damage at that point. Mild hypothermia, so that's where you're going to see a lot of the kind of the early stages, and this is maybe where some of you have gotten to before as far as some of your symptoms. But at mild hypothermia, you're usually alert and you're conversing, but you might be shivering quite a bit. You might be kind of shivering uncontrollably. You might not be thinking totally clearly, like you're conversing, but you're just a little bit confused. Usually with this, we see people, they're actually breathing a little bit faster because they're shivering, they're cold. They might be actually tachycardic. Hyperventilating a little bit is pretty common in mild hypothermia. As we get to moderate hypothermia, it's getting to be pretty severe at this point. Usually moderate hypothermia, you're starting to see a decreased level of consciousness. And it can come with or without shivering. So people always, at least growing up, I always heard this phrase, if you stop shivering, you're in trouble. And I think that's true because usually that's kind of in this mild to moderate staging is where you start to see people being less likely to be shivering towards the ends of this stage. This is where you start to see, cardiovascular collapse. We start to see hypotension, decreased cardiovascular output once we get this temperature. You see that CNS depression. That's why people have decreased level of consciousness. Again, that people have, decreased reflexes and things like that. And then severe hypothermia. This is a life or death issue. People are often unconscious, not shivering at this point. Associated with it, you see a lot of different end organ dysfunction. So you might see like pulmonary edema where they get a lot of fluid in their lungs. Oliguria, so they're not perfusing their kidneys because their vessels are so constricted down due to the extreme hypothermia. You might notice people are in a coma, they're unresponsive, they're super hypotensive, bradycardic. You might even see like arrhythmias with this, some of which can be like VFib and other life-threatening arrhythmias. And you can actually see loss of like corneal and oculocephalic reflexes, things that we oftentimes associate with, different, neurologic outcomes and things like that go away with cold. The management of hypothermia is very stage specific. In general, the one thing to think about is if anyone is in a wet condition, you're called to the scene and they are in wet clothes out on the wet sidewalk or in the field hunting and they are, laying in the snow, get them out of that situation, get them into warm clothes or a warm blanket. Typically mild hypothermia, it's just passive external rewarming. So getting them out of that cold environment and getting them, warm blankets, letting their body heat, their shivering kind of regenerate that heat and bring their core temperature back up. We start getting into moderate hypothermia, then a lot of times we're starting to talk more about doing not only active external rewarming, so blankets or, other forced ventilation air warming systems, bear huggers or things like that, where you're actually blowing warm air through a device past the patient. but also doing internal rewarming where, you might be doing, warmed fluids or things like that as well. Severe hypothermia, again, is the same thing. It's both internal and external rewarming, but just at a higher range. Obviously, this is not going to be happening in the field, but these are patients who, might need, warmed fluid irrigation through their peritoneal fluid, through their pleural fluid, through hemodialysis or cardiac bypass, um, things like this. The other thing to think about, so if you go to a call and a patient is in a cardiac arrest and they're in severe hypothermia, a lot of times the shock doesn't work in this situation. So you might be doing CPR and shocking patients, but the defibrillation is not as effective unless you get their core temperature up above kind of like that 30 degrees Celsius mark. And so that is kind of where, if you come in and someone's got this severe hypothermia, you really got to get them out of that environment, get them rewarming while doing resuscitative measures, in hopes that as their temperature starts to get a little bit warmer, that you'll start to see more effect. The other thing that unfortunately we see kind of, sad news article or two every year about, drownings. I think, a lot of it is, particularly I think in this situation, you think of your waterfowl hunters. Occasionally there's, different big game hunters that are using water access to get to different areas. But for the most part, this is going to be like your waterfowl people. And a lot of times waterfowl hunting takes place late into the fall. Some of the best hunting is as the temperatures are getting cold, right around the time where sloughs and lakes start making ice. With ice can come, windy days and bad weather. And a lot of times that's where, unfortunately, it seems like in the state a case or two a year where we'll get a drowning episode where a boat capsizes and people unfortunately lose their lives in those situations. The big thing from an EMS standpoint with drownings, not only in this situation are you dealing with hypothermia, but in a drowning situation, you're oftentimes going to find the patient is, depending how long they've been in the water, they may be pulseless and, having no obvious respirations. It might be a cardiopulmonary arrest situation when you find them. The big thing on resuscitation with drowning victims is actually a focus on ventilation. And so more and more, a lot of the, American Heart Association and those different entities are focusing more on kind of hands first CPR, compressions first. And what we're finding with drowned victims is it's really a ventilation thing. So in an ideal situation, you want to be giving rescue breaths, either with a big valve mask or whatever you have available first, giving a couple breaths, getting chest rise, evaluating pulse, then starting CPR, rather than starting with compressions right away. I think the other misnomer is sometimes people think, Heimlich maneuvers, trying to get them to, cough up or spit out that water. Different techniques can help, and really it doesn't. I mean, if you're in this situation, it's going to be a matter of, good ventilation, and if it is someone who is in cardiopulmonary arrest after drowning, high quality CPR. Eye injuries are another thing that I think of a lot. These aren't necessarily emergencies. Honestly, it might not even be stuff that you're called on scene, but if you're out in the community and different things like that, you may come across. I always kind of chuckle when I think back to the Christmas Story, hence the picture where you're going to shoot your eye out. And I think nowadays people are getting better about eye protection, but definitely not everyone is wearing eye protection. I think there's a lot of things when people are out hunting that can cause eye trauma and ocular trauma. Cattails, people bending down in sloughs, either duck hunting or pheasant hunting, can get poked in the eye and get a penetrating injury. Thinking through hunting, I think a lot of situations involve, pheasant hunting where people are walking and maybe blocking at the end of a field and kind of generally shooting towards each other. Certainly, at a distance like that may not, harm you if you hit in the arm or the leg, but if it can hit you in the eye, you can have a foreign object in the eye. navigating through terrain, tree branches getting snapped back in the face and things like that. Eye injuries, for the most part, this is someone who's going to need to be seen in a local facility. A big thing to look for, particularly with a penetrating injury, is if there's a disruption in that iris. A lot of times that'll kind of signify that there's maybe a globe injury. If there is something, that is stuck in the eye, a cattail is stuck in the eye, a BB is stuck in the eye, a small branch is stuck in the eye, I would say from an EMS standpoint, I would never really try to take that out in the field. Probably the best thing to do would be to either, if it is a small foreign body, you can either just put like a patch over the eye to protect it, or if it's a larger foreign body, say someone bends over and they have a large piece of cattail stuck in their eye, trying to stabilize that where it is and then letting, whatever center you transport that patient to get that out. Fishing too, you could see that fishing hooks and things like that. I know this is a hunting specific lecture, but I think in general, the outdoors, eye injuries are definitely more common. Animal bites. This is something that I think we see, particularly people in the outdoors. A lot of times animal bites are going to be a dirtier bite that, may or may not be something that's an emergency or where EMS is mobilized, but you might be first responders to different calls. In general, I think the biggest thing that I think about with animal bites, besides getting it cleaned out well with like soapy water or hydrogen peroxide or, betadine scrub and just getting it clean as soon as possible, is kind of that rabies component. Working in our local ER last year, actually had a case where a guy was out pheasant hunting and the dog was on point and he thought it'd be kind of funny and try to catch the raccoon that was getting pointed by the dog, and thought it was a rooster pheasant, went climbing in, and the raccoon bit him out of self-defense. And unfortunately, in those situations, you have to worry about rabies, and that's something as EMS providers, maybe it's not something you're actively treating, but you can really help facilitate your local facility. If there's a couple things you keep in mind, one, if at all possible, to capture or retain that animal, that could be very helpful. But it has to be done so in a way that doesn't totally destroy brain matter. So a lot of times people get bit by a raccoon and they get so frustrated they shoot it in the head and they destroy the brain. Well, then that can't be tested and sent. And so really, if you're ever called in these situations and they know where the animal is, if they can bring it in to their local veterinarian or something like that, sometimes we can test the animal and save the person having to go through the rabies vaccine and immunoglobulin series. The other thing I think in these situations, is just helping to facilitate that a person does seek follow-up to some degree. I mean, it's probably good, even if it's not an emergency room situation, that they at least be seen in the clinic thereafter, because a lot of times these types of animals have smaller teeth. It's more of a puncture type of bite. It's more likely to get infected down the road, similar to like a cat bite where we might be more inclined to put someone on antibiotics. This is a little bit less, our part of the state on the eastern side here. But I think as you get a little closer to the river, we're starting to see, occasional, snakes on the east side of the river. I think it's not something to be completely naive about. We definitely have poisonous snakes in this state. If you're ever called to a snake bite, the first thing is obviously to get that patient away from the snake. Most of the time this is done by the time EMS has arrived, but trying to just make sure that, that patient and you are out of harm while you're trying to provide care. There's a lot of, tales about, tourniquets and sucking venom out of the wound. And a lot of this really has not been shown to help. Best thing on scene that you can do is if this person has a ring on their finger or a band on their hand, or watch, something like that, get anything off, because there is likely to be local swelling. And so trying to remove anything that could be constricting, even clothing in that area, tight fitting clothing can cause constriction down the road as that tissue swells from the venom. Immobilizing that body part, we want to try and kind of get that body part in general at the level of the heart or so, in a functional position. You can kind of splint it and keep it supported, but we really don't want to moving and mobilizing that tissue a lot. I have read some different things. In general, snake bites cause a lot of local necrosis, but they can also cause systemic symptoms as well, from the venom itself, which can, include hypotension and things like that. A lot of times, if you're worried about local swelling and tissue necrosis more so, if you elevate the extremity a little bit, it can kind of help reduce that at the risk of some of that venom actually working more downstream with gravity into circulation and putting you at risk for more of kind of the systemic effects. Conversely, if a patient's having more systemic effects, if they get bit in the leg, having that leg down, the thought is that it might slow spread into circulation until you get them to a local facility. But in general, I think the rule of thumb is kind of in a neutral position and really trying to minimize them from mobilizing that tissue a ton. You can cleanse the wound on scene, that's totally fine, and then getting them to their local facility so that they can be transported to a facility that has the anti-venom. But I do want to reiterate the fact that we really do not want, pressure dressings or tourniquets. If you're going to splint, it needs to be something loose fitting that allows some ability for that swelling to occur without causing constriction. The other thing is, in South Dakota, there's really kind of one major type of poisonous snake. In other parts of the world where there's different types of poisonous snakes, it can be helpful to have a photo to help the local facility identify exactly what type of snake. But for us more locally, in general, if someone has a snake bite that we're truly worried about, it's going to be more rattlesnake. So this kind of gets into the big parts of, I think hunting injuries, and I think of, big cuts, big injuries. And we see this a ton. I think, people are cleaning their game or gutting their deer. Commonly we see, different hand injuries needing stitches and things like that. A lot of times that's not something that's necessarily going to mobilize EMS, but is something that we commonly see just because people are using knives in a situation where they're prying and prodding and really trying to utilize that knife and that tool probably above the strength or the movements that they really should. Other things I think about, barbed wire, people crossing barbed wire fences and things like that, you can get lacerations there as well. In general, lacerations, the way to kind of best treat these, when called on scene in an EMS setting, is going to be, trying to get that bleeding to stop. Certainly applying direct pressure, is kind of the gold standard, and you can do that. I would do it with a gloved hand. This is probably not the best picture for that. Pressure dressings can be another option too, and there's a lot of ways to do pressure dressings. There are some that come, prefabricated in like an ACE wrap that has like a gauze built into it. You can also do it, with Coban, with Curlix. If you're having difficulty getting, enough pressure broadly, sometimes taking like a roll of gauze to apply direct pressure more firmly over that area and then wrapping it can be a good trick to try and get bleeding to stop. If all of this is not working and bleeding is not stopping, sometimes we do think about tourniquets, and generally we limit tourniquets to life-threatening bleeding that's not stopping with conservative measures. I think everyone's always afraid to use a tourniquet because you worry about neurovascular injuries and things like that. But tourniquets can save lives, and I think the biggest thing is knowing when to use a tourniquet. If you are applying direct pressure bandage, you're soaking through it, people are starting to show signs of hypovolemia or you're not able to control the bleeding, that's the time to use a tourniquet. The other thing to kind of consider is appropriate tourniquet use, and knowing how to use them correctly, and to kind of go through the different types and all of that. I don't know as high of yield, but if you have a tourniquet on your rig or in your bag or in your facility, I would just be aware of what style you have, and if you don't know how to use it, having someone briefly show you or looking it up. In general, I would say most styles are comparable, and they involve a strap that goes around, and basically you'll put it around the extremity and kind of pull it as tight as you can to a degree. And then you can utilize this rigid portion to twist around and tighten that, and then can lock it in place. There are definitely other styles though, and so I guess I would say rather than going through a bunch of different styles is knowing what your local facility or rig has, and just being aware of those and comfortable that if you ever do have to use them, that you're able to apply them appropriately. The other thing to think about is a lot of times it is nice to know what time, and some of them nowadays actually have a spot where you can sign time. But if you're applying these, it's nice to know what time they go on so we know how long that tissue has been without blood flow. Projectiles is kind of the thing I think about it. These are going to be kind of your catastrophic injuries. Someone accidentally gets shot. I think these are things that we all hope to never see or to not see with much regularity, but they do happen. Most of the time I think of, gun injuries, but you can actually see it with bow and arrow stuff too. I wouldn't say it's a common injury, but as people shoot arrows over and over, if that arrow gets damaged, there's, multiple cases where those arrows can actually almost explode and fray. Nowadays, most of the time they're made with carbon fiber, and that carbon fiber can splinter. I would say if you ever find a situation where there is an arrow impaled, I think the big thing that I would say is stabilizing that arrow as you see it, not pulling it out on scene, and getting that patient to a local facility so that they can get in line with an appropriate surgical consult to get that removed in a safe and controlled environment. That way, if there is bleeding complications as you remove that foreign body, it's correctable. I think there's a lot of things to talk about as far as projectile injuries, but in general, things that I would consider are, what is the caliber of weapon, particularly for gun? Is it a shotgun? Is it birdshot? Is it a rifle? What caliber, what distance? Looking for location, entry and exit wounds. Using that to kind of fuel your differential diagnosis on possible injuries. And a lot of it comes back to, supporting, transporting as safely and as quickly as you can to a nearby facility, and probably a surgical consultation. Which kind of brings me to, my general wrap-up point in conversation as I kind of came through this story or this presentation, and, trying to think through, what things can I share about hunting injuries and, the EMS setting. And it truly all comes back to your primary and your secondary survey, which sounds a little bit cliche, but it's really where, no matter what injury or incident you're faced with, if you keep these things in mind, you're never going to be wrong. You're always going to be prioritizing and triaging your patient appropriately and providing them with ultimately the best care. For a quick review from a trauma standpoint, is the patient talking? If they fell out of their tree stand, is there evidence of fractures? Do they have a hematoma on their neck? Is there anything that you're concerned about where they might lose their airway soon? Do they hit their mouth? Are there aspiration risks such as teeth, blood, vomit, things that need to either be secured or suctioned out? Management, you want your head in a neutral position, particularly if there's, a fall or an injury. Typically the jaw thrust maneuver is better in trauma than the chin tilt, because you're not moving that neck and not risking cervical spine mobility in a patient who might otherwise have other injuries. The hallmarks of, maintaining your airway, suctioning, supplemental oxygen is needed. If you need to use an OPA or an NPA, oropharyngeal airways or nasopharyngeal airways, uh, using an LMA or other type of supraglottic airway, or depending on credentialing, skills available if intubation is needed. Breathing, what is the patient's work of breathing? Can they talk to you comfortably? Are they tachypnic? Are they really, stridorous or working to breathe? In addition to that, how effective are they breathing? Is their oxygen saturation normal? Are they, is they having chest rise, tree stand injuries or falls? Certainly you can see, flail chest, pneumothorax, different contusions, gunshot injuries, certainly, pneumothorax and things like that could be, hemothorax could be, things that you need to consider. Your management, the life or death things, tension pneumothorax, depending on your certification level and whether or not needle decompression is within your skill set. If you have an open pneumothorax, getting a dressing over that, flail chest, bagging them or doing some form of PPV. Circulation, I think a lot of this comes back to, the easy bleeding to treat is the external bleeding because you can see it. You're going to see these lacerations, these open fractures, amputations potentially. This is where your direct pressure, your tourniquet, those types of things come into play. The internal bleeding is where it's a little bit more challenging. They might have a chest wall injury, maybe abdominal pain, if you notice rigidity or tenderness. A lot of this is going to be clued to you with your vital signs and noticing, oh, this patient is, hypovolemic, their blood pressure is low, they're tachycardic, they just had a fall, I should be worried about this. These are patients where if you're capable of, getting IV access, 1 to 2 access points and getting fluids going right away is going to be important. And also, getting them transferred to your local facility. Disability, your AVPU, is the patient awake? Are they verbal responsive, painful stimulus responsive, or unresponsive? And your GCS scales can be helpful in kind of determining that. Worrying about cervical spine injuries, spinal cord injuries, trying to keep people that have trauma as stable as they can, stable on a backboard with a seat collar, trying to minimize those types of movements. It's hard. It's always easy to say, yep, don't let the patient's neck move from the time you're on the field. But if you're called to the middle of a slough or someone's basement and you're supposed to get a 300-pound person up the stairs and out the hallway without moving their body at all, realistically, this stuff could be a extreme challenge to do. And so we try and do the best we can. I think we need to be conscientious of it. But I also acknowledge that a lot of times these situations can be tough. Environmental exposures, and this kind of comes back to, some of the things that we talk about hunting related, particularly with the hypothermia and the cold weather stuff. But, what are the chemical exposures or wet clothes, trying to remove those things, if they were in any sort of contact irritants, getting them warmed up. A lot of times those are kind of the hallmarks. And then, once you get through your primary survey, you find stability there, working through your secondary survey. And this is a lot of times, the vast majority of patients have secondary survey type injuries where, they injured their arm or their leg or they fractured a hip or things like that. And so, just these are things that with experience, you are all doing within a matter of seconds, getting through your primary survey into your secondary survey. But sometimes just going back through and thinking through the process, no matter the mechanism of injury, if you're able to go through these steps in a trauma setting, it's almost cookie cutter type of medicine because you're always going to go through the same step-by-step algorithm for the most part. And that's kind of all that I have as far as specific presentation. Like I said, it's a little bit short from a content standpoint. I think talking through specific injuries gets to be almost more time intensive than what we have. But I'd love to, field any questions at this time. If people have any specific cases that they've experienced and they want to talk through, or other questions regarding things they've seen or been told previously or the presentation, I'd be happy to answer anything.
All right, anybody have any questions? You can either put them in the chat box, or you can go ahead and ask them. Just ask you guys not to leave yet, because we will have a survey at the end that you're going to need to fill out, and that's partially how you're getting some of this credit. So, anybody, any questions, any comments, any concerns? I guess maybe I'll just throw a comment out there. Is also in these types of incidents where you may get this call and somebody tells you they're in a field someplace, they've fallen out of a tree stand, is don't hesitate to, call out the cavalry, get resources coming, because if you're not exactly sure where they're at, and if we're dealing with a day where it's pretty cold, and we're dealing with a trauma situation, but then also we could start dealing with the exposure possibility. So make sure that you're making those calls, you're getting your resources coming, and err definitely on the side of caution. Don't hesitate to make those calls right away. Can always turn them around, but if we're 15 minutes behind the 8 ball, we're going to be trying to catch up all day. So we got a question that came in. Can you go into more detail about what are different options of first responder treatments for gunshot wounds?
Yeah, I think that's a great question. I think gunshot wounds particularly depend on location. And, a thoracic versus an abdominal versus an extremity gunshot wound are all going to be very different. I think as far as treatment, it's going to depend a little bit on the location. If it's a thoracic injury, you're worrying about cardiopulmonary damage. And so you're going to really be focusing on supporting those organs as best you can, in addition to stopping bleeding. I think stopping bleeding is kind of a universal goal of any, gunshot wound type of injury, if possible. I think in general, direct pressure, pressure dressings, sometimes if there's an arterial bleed, you almost have to, grab that artery and pinch that artery directly, or pinch upwind or upstream of that artery. There are different quick clot, different substances available that you can apply, certainly if you have those available. But in general, it's going to be pressure over those areas and then supporting anything underneath. So particularly, I would say from an EMS standpoint, an abdominal injury, there's not going to be as much that you can do in the field, because that person needs to see a surgeon. They need someone to go in, do a laparotomy, sew up any bleeders, but that patient needs to have IV access, and externally, at least, you can be trying to control the bleeding. From a lung standpoint, you're worrying about aeration and things like that. That's where you might be doing your dressings for like pneumothorax or those types of things if you're worried about lung inflation. Extremities, if you have an extremity injury, someone's shot in the leg and it's on their femoral artery, that might be a situation where you need to think about a tourniquet. But I think in general, like quick clot type substances, pressure, different dressings like that are going to be kind of, unfortunately, about the best things that you can do in the outside facilities, particularly if you're in the rural setting, you're 5 miles off the gravel road, because that's, a lot of times this stuff doesn't happen at Walmart downtown. It's going to be, out in the middle of nowhere. And so trying to get a dressing on that patient, but also, not really hindering your mobility and trying to get them moving towards a facility is probably your best treatment, honestly.
All right, great. Any other questions? You can either unmute and ask your question or drop it in the chat box. I guess maybe, Doctor, if you wanted to maybe touch on a little bit some of the allergic reactions that we might see somewhat from our folks that are out in the field, and then kind of how to handle some of those.
Yeah, I think allergic, that's a very good point and not something that I necessarily touched on. I think a lot of times people that are outside, bee stings are one thing that always comes to mind, that anaphylaxis type response. But poison ivy, other things like that can cause pretty substantial diffuse reactions. I think when you start talking EMS in a life or death situation, I think of the anaphylaxis type reactions, those different stings and bites. I think the hardest part that I always struggle with when I see patients with allergic reactions is this anaphylaxis or not? And I would say in general, it's probably better to be precautionary and proactive than it is to be, um, dragging your feet and getting into a hurry, because people's airways can swell pretty quickly. You can run into stridor and airway edema in a hurry. And so I think if you have people that are starting to show signs of anaphylactic type reactions, the hallmark that we do in the ER is typically a combination of Benadryl, which, for most people can be available even through, EMT type situations, or readily available nearby. Otherwise, you think of your other antihistamine medications. So one of those can be famotidine or Pepsid, which is actually like an anti-reflex medicine. Steroids, Decadron is commonly used for that. Oftentimes in an adult, I'd give like a 10 milligram dose. And then if it's truly someone that you're worried about respiratory distress, anaphylaxis, that's where that epinephrine or an EpiPen kind of comes into play. And that's really the life-saving situation if you have someone. If it's someone who's, you're worried about airway, the best, safest way to keep that airway is through intubation. But you can get people with, localized tongue edema and things like that in that situation. If you're a basic and maybe you're not able to do intubation, even like an NPA or something like that, just to kind of try to get past the initial portion of the tongue to the back of the throat. They might still have some posterior swelling, but it's probably better than nothing until you can get them to someone who's able to intubate and more definitively take that airway.
Sure, great. Any other questions? I know some of you guys weren't this quiet this weekend, so here we got one. Could you clarify when and where to pack penetrating wounds, abdomen versus limbs?
Yeah, that's a great question. If you have a gunshot wound, I would pack it no matter where it is with, sterile type gauze. I don't think in any situation you're ever going to be wrong in that. They can always take it out in the outlying facility. Now, abdominal can be a little tougher depending on the caliber. If you have a smaller caliber weapon at 22 or something like that, it's probably hard to do a large packing. Some of those larger caliber weapons can leave pretty big holes to where you could kind of pack a crazy amount of stuff into an abdominal wound. In general, I don't think you're ever going to be wrong to pack that situation. If it's a larger wound, they're going to need surgery. Someone's going to go in and take that packing out. And so I think I would keep packing if you're still having bleeding. I think once you stop having bleeding, I'd stop packing, is kind of my general rule of thumb. Now, that is, every situation is slightly different. And I don't know that there's one specific catch all, but I think I would try to pack until bleeding is controlled, and then I would probably stop. I hope that answers your question. I know some of these maybe don't answer it perfectly, but.
All right, we got any others? Any comments? Anybody been on one of these yet this year? You want to share your story? All right. Well, I don't think we're seeing anything else come in. Thank you very much, Doctor, for presenting to us tonight and giving us that the good information that you gave us. And we really appreciate you taking time out of your schedule and also just getting over a cold. I know how terrible that can be sometimes to present when you don't feel well. So thank you very much.
Yeah, thanks for having me, and thank all you guys, for what all you do. I know There's a lot of different EMS experience levels here and criteria, and just appreciate for what you guys are doing out in the field as well. It takes a full team effort, and I just appreciate the opportunity to come and talk with you guys tonight.
Thanks a lot. Michaela, do you have survey to put up?
Yes, yep, I will put that up right now.
All right, so scroll down again if you don't remember. There's more questions, so go ahead and answer those as they come up there. And I'll also let you know that we have had I think a record number on tonight as far as people who are getting credit, so that's great. Also, make sure you're telling other people in your group, in your services, that we have these. Next month's will be on December 2nd, right, Michaela?
Yes.
Due to the Thanksgiving holiday, we will be meeting the following week, December 2nd. And then when we get into January, we will go back to the last Thursday of the month. So 2 months of kind of a little bit different, but then we will go back to kind of normal in January of 2022. So also, if you have not registered on the portal, go ahead and do that. I did pick out a lot of names that weren't in the portal that were on here tonight. I did register you. So they said something about the surveys disappearing.
Oh,
There was only 2 questions there.
okay, let me retry this quick. Sorry. Okay. If you guys want to try again, I apologize.
There, it looks like we're working.
There we go.
So again, thanks a lot, everybody, for being on tonight. Once you get the survey done, I don't have anything else. Michaela, do you have anything?
Nope.
Sandy, anything?
No, just thanks for participating.
All right, great. Make sure you're answering that survey, and hopefully you guys have a great evening. And we'll see y'all again in December.
Thank you.